Zach Cox, Mike Gibson, coming to you from ESC 2023, and we are talking about the DICTATE acute heart failure study, looking at the early initiation of Dapagliflozin in patients with acute heart failure. Zach, talk to us a little bit about why you did it and what you found.
Yeah, thank you for having me. The reason we did this study is because although there's a wealth of data of the efficacy and safety of SGLT2 inhibitors in chronic heart failure, and even starting SGLT2 inhibitors just before hospital discharge and examining sort of the intermediate outcomes over 3 to 6 to 9 months post-discharge, there's really an evidence gap in the efficacy and safety of early SGLT2 inhibitor use in the hospitals. And we know that approximately 80% of candidates for SGLT2 inhibitor use during acute heart failure hospitalization are discharged without them. So there's a great need to study this and to understand both the safety primarily, because that's usually what holds people back from starting these therapies, concerns of increased risk of urinary tract infections or hypoglycemia or ketoacidosis, et cetera, during the hospital worsening kidney function. And then to really understand what's the efficacy. Is there any efficacy beyond just starting them as GDMT, which is very impactful, but is there any impact on diuretic or decongestion outcomes?
And when you say early, Zach, how early is early?
Yeah, so in DICTATE-AHF, we randomize people within 24 hours of presentation to the emergency room or to the hospital if direct from clinic. So we started these on the very first day prior to stabilization and really continued them for either up to 5 days or discharge if sooner.
And in terms of concomitant meds, I mean, everyone these days is talking about getting everything started at once. What was the strategy there?
Yeah, in terms of concomitant GDMT, that was left up to the primary team. We did protocolize IV loop diuretic and thiazide diuretic titration. So across both treatment arms, they received the exact same protocolized IV and thiazide loop diuretics to really answer the question of, against structured usual care with an aggressive diuretic titration protocol targeting a urine output of 3 to 5 liters a day, what is the benefit of adding in an SGLT2 inhibitor early on the decongestive outcomes?
And how many people did you study, and what was your primary endpoint?
Yeah, so we randomized 240 patients who were hospitalized with hypervolemic acute heart failure. Early on, we only included patients with type 2 diabetes. We had a protocol change a little under halfway through the study where patients with or without type 2 diabetes were included. And the primary outcome was looked at efficacy was diuretic efficiency. So that was calculated by the cumulative weight loss over this study period divided by the cumulative loop diuretic dose given over the study period.
Interesting. That's a new endpoint I hadn't heard of. And what did you find?
What we found is that the addition of dapagliflozin to structural usual care improved the odds of improved diuretic efficiency. This was a model that adjusted for baseline weight, and so it's expressed in odds ratio. So it improved this. The odds ratio was 0.65 with a 95% confidence interval ranging from 0.41 up to 1.01 with a p-value of 0.06. And so the upper limit of the confidence interval did exceed 1 for the diuretic efficiency outcome.
It's interesting. What do you think the mechanism of DAPA is? Is it a smart diuretic or lots of other mechanisms? And, obviously, if you add a diuretic, are you going to get more efficient diuresis?
Yeah, I think, of course, under a lot of study of what are the multiple mechanisms by which SGLT2 inhibitors exert their benefit, what we observed in our study is that there is indeed in acute heart failure receiving aggressive IV diuretics a natriuretic benefit and a diuretic benefit. The dapagliflozin group achieved greater measured sodium output over 24 hours and greater urine output over 24 hours when we indexed that to loop diuretic dose. And to sort of quantify what that was, there was an 80 milligram of furosemide difference between the usual care group and the dapagliflozin group. And so dapagliflozin accounted for roughly 80 milligrams of IV furosemide in a 24-hour period to achieve equivalent natriuresis and urine output. And we also found that there was faster time to decongestion, meaning transitioning off of IV diuretics, and faster time to hospital discharge over the 5-day study period for patients who were randomized to dapagliflozin. So although over the whole period, the weight loss was similar, people on dapagliflozin got there with less loop diuretic and got decongested faster. And so there was a moderate diuretic benefit observed.
And that shortening of length of stay, that was statistically significant?
Statistically significant over the 5-day study period when we look at cumulative incidence competing for inpatient mortality.
So that could be obviously very important in a cost-effectiveness analysis. And was there any downside? I mean, with that more rapid diuresis, do you have any rise in creatinine or any problems there?
It's a great question. Safety was really important. A lot of all our safety was evaluated by a blinded endpoint committee, so that we would have a lot of our pre-specified endpoints looked at by this committee. We found no increased incidence of total hypoglycemic events, severe hypoglycemic events, and no ketoacidosis events. So across the glycemic metrics, dapagliflozin was very safe. No increased incidence of hypotension. The median eGFR change between enrollment and end of study was no different between DAPA or usual care, nor was the incidence of stage 2 or stage 3 acute kidney injury. And so when we looked across the spectrum of diabetic and cardiorenal safety outcomes, including worsening heart failure and 30-day readmissions for heart failure or diabetes-related readmission, dapagliflozin was safe to be started early in the hospital without any in-hospital or immediate post-discharge safety concerns, which was a real win.
Yeah. So Zach, where does this fit in? Does this change care? I mean, should people be using DAPA early in the first 24 hours?
Yeah, I think given the moderate size of the study and all the pre-specified safety outcomes where there was no signal for harm, that this should change practice in the 80% of patients who are hospitalized in acute heart failure who aren't being prescribed an SGLT2 inhibitor. I think what this gives us the confidence to do is to start an SGLT2 inhibitor early on the first day of an acute heart failure episode. We should accrue some decongestive benefits over the time that we decongest with hopefully less loop diuretic titration. And this will hopefully carry forward post-discharge so that patients can continue the chronic benefits of SGLT2 inhibitors, which have been well established in other trials. I think it leaves us with the question then, when we have all these recent studies of combination upfront diuretic therapies like the chlorotic trial, which studied adding a thiazide, or the ADVOR trial, which studied acetazolamide. Unlike those trials which deal with the acute decongestive issue but don't really inherently change GDMT and haven't really changed post-discharge outcomes despite improving decongestion, I think it's clear that we should add an SGLT2 inhibitor up front and only reach for other diuretic combinations if they're needed for diuretic benefits on top of an SGLT2 in loops.
Great. Zach, thanks for joining us today. Great presentation. And thanks to all of you in the audience for joining us here from ESC 2023.
Thank you.